Hello, everyone. Today, I will be speaking about the basics of osteoporosis. So we know osteoporosis is a systemic skeletal disease which weakens the bone and causes fragility fractures. WHO has defined osteoporosis as a T-score of less than or equal to minus 2.5 on a bone density measured by DEXA scan. So this is the way we quantify it. The DEXA is the gold standard. And this is what we should follow for the diagnosis. Just a bit of theory that for bone, you have bone cells and bone matrix. If your bone mineral is lost, that is osteomalacia. But if everything is lost, that's what is osteoporosis. So women are at increased risk of osteoporosis. We all know that. But it's not only about the females. The males are also at increased risk of osteoporosis. And we should consider osteoporosis in males, especially above 70 years. The consequences we know can be acute and chronic pain, increased use of analgesics, there is deformity, there is loss of quality of life, there may be a neurological deficit associated with a fracture, and this can severely impede their life and can result in increased mortality. Osteoporosis care gap is something which we all should know about, is that since we don't know the disease well, or we do not keep ourselves aware about the disease, there is a gap which remains and we do not treat it, and that leads to many problems. And that is why osteoporosis is a bone-shattering thunderstorm. It's not just a simple disease. To interpret DEXA is very simple. You have two scores, T-score and Z-scores. The T-score compare within a young adult and Z with an age-matched same-sex adult. And important point is, if any of your Z-score is less than -2, you should rule out secondary osteoporosis. Bone density scan, again, you have central measurements, which are spine and femur, and you have peripheral measurements, which are forearm. The Z-scores are more appropriate for patients less than 50 years, and T-scores, we should not rely on Z-scores above 50 years. So let's have a look at this DEXA scan with severe degenerative changes in spine and one hip replaced already because of rigidity fractures, and we may conclude that the patient is not osteoporotic. But unless you look at the wrists, the other hip, where the T-scores are -4.2, -3, that is when you realize that not a single value needs to be considered. The patient's, all the values you need to consider. There is something called as a qualitative CT. It's better than DEXA. It's not available everywhere, but yes, you can measure the volumetric bone and stress strain index. Fracture risk assessment tool is a tool which is devised by WHO to quantify the fracture risk, and based on that, you recommend treatment. It includes DEXA and other factors also, which again strengthens the fact that DEXA is not everything. So the basic investigations which we should rely on are the vitamin D, the calcium test. We should also do a PTH, creatinine, alkaline phosphatase, phosphorus. And in females, I especially recommend TSH or the thyroid test, because a lot of them are hypothyroid, and that is also a cause for osteoporosis. Whenever you take the calcium sample, ask them not to apply a tourniquet and use albumin correction for any unionized calcium which you are measuring in blood. Advanced lab investigations, they are the bone formation and resorption markers. The clinically relevant one are the P1NP. In resorption, we have CTX and beta cross labs. So non-pharmacological treatment of osteoporosis includes to identify early and sort of do regular exercises, brisk walking, take adequate calcium, vitamin D, and keep yourself healthy. The medical management comes when you have osteoporosis, and you may have primary or you may have secondary osteoporosis. The primary osteoporosis can be type 1, postmenopausal or senile, and secondary be due to many other reasons or diseases. Now let's look at two scenarios where the bone formation is good, bone loss is good. And in this scenario, you just need to plug the leak and you will fill up the tank, you will fill up the bone. In other scenario where the loss is also less and the formation is also less, as happens in senile, patients, you just by plugging the tank, you will not get the desired outcome. So you need something which can fill in. So you have an anabolic agent over here, which works better and fills up the tank. And once it's filled up, you want to plug it by an anti-catabolic agent like bisphosphonate or denosumab to plug it. So the pharmacological treatment based on these scenarios can be anti-resorptive or anabolic. We know anti-resorptives include calcium and vitamin D, hormonal replacement therapy, calcitonin, bisphosphonates, and denosumab. Now, should ensure that you take adequate calcium, especially natural sources are the best. Injectable vitamin D is not better. It leads to more toxicity. And if you choose to give it, do not give more than one injection. That is good to last for 6 months. Calcitonin is reserved only for hypercalcemia because of multiple metastasis or recumbency and is not recommended as an anti-osteoporotic treatment. Bisphosphonate, before we start bisphosphonate, we should have a normal kidney function, and you cannot give oral bisphosphonates with creatinine clearance less than 35 ml and injectable less than the alendronate and zoledronate less than 35 ml and the risedronate and ibandronate less than 30 ml. So you may have to ensure that vitamin D is normal and the oral absorption of these is very less. So you need to take them empty stomach early in the morning and not have food for around 45 minutes after taking the tablet. And don't sit as well because they are slightly irritated. Now, the recommended use of these agents in prevention of osteoporosis, you can see that alendronate is not recommended for prevention of glucocorticoid-induced osteoporosis, and ibandronate is not recommended as treatment in men. So this is what 2 points we should consider, and also not for glucocorticoid-induced osteoporosis prevention. You see, every drug which is there works well on spine, but it's only the zoledronate which acts on hip and wrist as well. So if you have severe osteoporosis of hip and wrist, then giving oral alendronate is not the best option. You should choose zoledronate. Denosumab is a monoclonal antibody against the rank ligand. It is approved for 10 years. It's renal friendly, but has got increased hypocalcemic risk. It's cleared by reticuloendothelial system. There are certain risks for skin infections or skin events, and most likely we plan a switch therapy at the end of 5 years before we suddenly discontinue. So you should not suddenly discontinue the denosumab if it's going on. You have to give a crossover to a bisphosphonate before you stop it. Especially this applies when the renal function is normal. Anabolic agents, the most important one is the teriparatide, which is used in the clinical scenarios. It's recommended up to 2 years to be used once during lifetime. 20 microgram daily is as self-administered subcutaneous injection. There were concerns of malignancy in certain animal models, but again, it's not proven. But in any patient of malignancy, we should not use teriparatide. You can check P1NP before and after 3 months of starting teriparatide. It gives you an early indication how well the injection is working. And check serum calcium on therapy. Give a gap of 8 hours between taking teriparatide and checking calcium, because there is a slight hypercalcemia which happens immediately after the injection. We just want to see the resting or the trough values of the calcium here. Teriparatide is recommended in postmenopausal osteoporosis, in senile osteoporosis, and glucocorticoid-induced osteoporosis. And above that, there is a combination therapy as well. And you can combine teriparatide and denosumab together and then follow it up with the anti-resorptive. And this has been shown to give the best result. The take-home message is that prevention is better than cure. Identify the target population early. Identify the people at risk. There's custom-made therapy for each individual you need to decide. And the most important is ensure compliance. Thank you very much.